Hello and welcome to the Super High Yield Anesthesia Podcast, the second edition. This is your host, Scott, the anesthesia resident. All right, thanks for tuning in to episode 10 of the Super High Yield Anesthesia Podcast. And today is part 2 of the trauma anesthesia series. And today's episode is initial evaluation of trauma patient, airway management, and breathing abnormalities. If you have the time, I would appreciate if you do the pre-survey before listening to the episode. But if not, let's go ahead and get started. So for the initial evaluation, you are essentially going to be in the trauma bay, assuming that you're going to respond to it as well. Usually when you are in the trauma bay, there's the trauma team there. Our institution consists of the emergency medicine physicians, the trauma surgeons, as well as the trauma nurses. Usually here, our trauma surgeons does the primary and secondary surveys, and the emergency medicine physicians, they help with like other parts of the secondary survey, such as doing the EFAS exam. But I'm jumping ahead of myself. Let's actually talk about what a primary and secondary survey is. The primary survey is something that you do to assess the ABCs of the patients after they rolled into the trauma bay and they get report from the EMS. So primary survey, basically you are assessing airway and cervical spine, breathing and oxygenation, circulation and hemorrhage, disability and exposure. So I guess they're adding on D and E. So A, B, C, D, E. So airway, breathing, circulation, disability, and exposure. So easiest way to assess airway is to ask them what their name is. And if they're able to respond or if they're yelling, that means that their airway is protected. But if they're not responding, bleeding everywhere, then airway is not secure. And then you're going to have to intubate the patient. Breathing, you can assess that by auscultating for breath sounds bilaterally. You can feel their chest rise or watch their chest rise and making sure that it's actually adequate breaths versus like agonal breathing or something like that. Assessing oxygenation as well. You place on the pulse ox and you check out the O2 sats that way. Circulation, easiest way is to feel for pulses. So radial pulses, carotid pulses, femoral pulses, and so on and so forth to make sure that there's adequate blood flow going around. And also, if you're taking a blood pressure, that'd be a great thing to do as well. Disability, things like fractures that you'll be noting on the primary exam, and exposure. So if they come in with like some sort of poisoning, like a chemical plant explosion or something like that, that's something to consider, and you have to immediately get rid of all their clothes to limit the exposure so you can like wash out whatever is going on. So that's the primary survey, just the absolute essential life kind of measures. So airway, breathing, circulation, disability, exposure. Okay, once you do the primary survey, the secondary survey is pretty much a more in-depth examination of the patient, and this includes labs and imaging as well. So you're going to go through systems based. So you're going from the top down, noting any sort of like lacerations or just anything on that you find, you just yell it out. And then there should be like a scribe that's documenting the findings. Okay, so for example, top down, checking the eyes, checking the ears, checking oropharynx, checking the neck, checking the chest for any like deformities, checking abdomen for distension, those kind of things. Okay, you kind of go top down, do a very thorough exam, and then you're going to have the team help you stabilize the neck and roll the patient to the side so you can take a look at the back, and you're going to palpate on the back as well to check for any point tenderness, because that's going to guide you on the type of CTs that you're going to obtain. Okay, essentially the initial tests that you're going to get are the standard labs, so CBC, CMP. If you're able to get an ABG, that'd be perfect. Imaging wise, you can do things like chest x-ray, pelvis x-ray, and CTs accordingly to the injuries. Generally, at least at our institution, we always do an EFAS as well. And EFAS stands for the Extended Focus Assessment of Sonography and Trauma, which basically you're just looking for fluid buildup and just any signs of internal bleeding that needs to go to the OR. Okay, other than that, you can do EKG, CT, as we talked about before, and other labs like coagulation stuff like TEGs, and of course, especially if you're concerned about some sort of hemorrhage, you're going to get a type and screen, or if you need to quickly type and cross. Okay, so that was the quick and dirty explanation of what happens in the trauma bay regarding the primary and secondary survey. So for us, as part of the anesthesia team, one of our biggest things is the airway evaluation. And the way we manage the airway is going to depend on the type of injury and the nature of the injury. Quick and dirty criteria for the need for intubation include the following. Things like maxillofacial trauma, major hemodynamics instability, low oxygen saturation, burns, head injury, intoxicated/behavior, possible safety issues to the team, and lastly, if you need to transport to radiology, OR, ICU, or transfer to another facility if the patient is hemodynamically unstable or uncooperative. So one of the major things to look out for in trauma patients is the possibility of airway obstruction. And this is the most frequent cause of asphyxia in trauma. And a lot of times it's due to like a posteriorly displaced or lacerated pharyngeal soft tissues, like a hematoma, secretions, or whatever stuff that happens during the trauma that causes it to back up and block the airway. Some signs and symptoms of upper and lower airway obstructions includes things like dyspnea, cyanosis, hoarseness, stridor, dysphonia, subcutaneous emphysema, and hemoptysis. And the initial steps for management for these patients with possible obstruction include things like chin lift, jaw thrust, and clearance of the oropharynx, so using like things like a suction. If you have it available, using an OPA or NPA, like the nasal trumpet. But you would generally avoid shoving stuff into the nose if you have any sort of concern for a basilar skull fracture. So, for example, if you see the patient has raccoon eyes, battle sign, or something like that, then you would probably avoid putting in anything in the nose, because if there's a fracture there, you could be shoving something into the brain, and that's obviously not what we want. So, especially if you are concerned about trauma to the head and neck, you want to have a C-spine immobilization and have supplemental oxygen as well. And if you think the patient is not securing their airway, it would be an indication to intubate. If it's not possible or it's like a difficult intubation, you can't get it, using an LMA would be the next best option. Okay, and when you are assessing the patient, it's also a good idea to take a look at the anterior neck as well, especially the cricothyroid membrane. And the reason for this is just in case you're not able to get the tube in and nothing works, there's too much edema, there's too much blood or whatever, your next option to securing the airway, or your last option, is an emergency cricothyroidotomy. And this is especially true when you have severe maxillofacial, neck, or chest traumas. And of course, there are contraindications to doing a cric, mainly things like if the patient is less than 12 years of age and there's laryngeal trauma. All right, and then that's basically the general overview on managing airway obstruction and trauma. Next, very quick section / is for every trauma patient, assume they have a full stomach. So you're never going to, do a standard induction for these patients. You can always do RSI. So rapid sequence dosaging, cricothyroid pressure, and securing the tube quickly. All right, next topic in airway evaluation is patients that come in with head, eye, or contain major vessel injuries. So for these ones, you want to have like a deep anesthesia and paralysis prior to intubating to prevent hypertension, coughing, or bucking, as this reduces intracranial / intraocular and intravascular pressure. So for these patients, when you're intubating, the strategy is pre-oxygenate, opioid load them, as this helps deepen the anesthetic, but without any big hemodynamic issues. And basically give them like a large dose of IV anesthetic plus paralytic. You want to make sure that they're deep and super paralyzed. It's interesting to note that ketamine does not actually cause appreciable increase in ICP and IOP, and that's intracranial pressure and intraocular pressure. And succinylcholine can actually be used in these cases as well, as long as they're given with a priming dose. Okay, next, C-spine injuries. In the initial evaluation, there's this thing called Nexus. It's the American National Emergency Radiography Utilization Study, where if patients meets the following criteria, they have a stable C-spine. So if patients do not have posterior midline neck tenderness, do not have focal neurologic deficit, a normal level of alertness, and no evidence of intoxication, they likely have a stable C-spine. But if they fail to meet any of these criteria, it's a good idea to get a CT C-spine. And regarding airway management, there's a technique called manual inline stabilization. And this is when you have two people to help intubate. One person stabilizes the head in a neutral position, and the second person stabilizes both shoulders. So basically, if you're stabilizing the neck, you're going to pretty much cradle the person's head with your forearms, and then you're going to grab the base of their neck and shoulders. And this helps stabilizes the neck while the other person intubates. So the other option is you can use video laryngoscopy to help reduce neck motion. And this is especially useful if the patient's already in a C-collar. Other options to manage the airway includes things like using a bougie, fiber optic, and if things really don't work out, doing emergency crike. Okay, the next section is any injuries, direct airway injuries. And the types we're going to cover today are maxillofacial injuries, cervical airway injuries, and thoracic airway injuries. So for maxillofacial injuries, usually this is the result of high impact injuries. So things like motor vehicle accidents, explosions, but they can also be caused by lower impact stuff, like, for example, getting punched in the face. And there's a special concern for, especially if it's like an explosion, like for debris and other things that could get into the airway and potentially block it. So, for example, foreign bodies, blood, teeth, hematoma, edema, anything, those kind of things that could cause an obstruction in the airway. So that's something to keep in mind for maxillofacial injuries. There's a possibility for massive hemorrhage if there's internal maxillary artery bleeding or other major arteries. So if this is the case, it's particularly important to secure the airway with an ET tube. And if the patient has limited mouth opening, due to pain, it's a good idea to utilize fentanyl. You can use 2 to 4 mics per kilo over 10 to 20 minutes to help reduce their pain and allow them to open their mouth a little bit more for intubation and whatnot. And like most things, the way you manage the airway is going to be dependent on the presenting trauma. So for example, if the patient has the maxillofacial injury, there's lots of bleeding into the oropharynx, you're going to have a lot of suction, like maybe even 2 suctions ready to go, and possibly utilizing direct laryngoscopy, considering that if you use some sort of video laryngoscopy, it could cause poor visualization. Because even if like a drop of blood gets onto the video, it kind of just occludes your camera, then you just can't see anything. So I've had like code blue intubations before where I couldn't get it. My senior end, I'm getting it. But basically, a good technique is to have both if you're using a video laryngoscope, have that and the suction going at the same time. Like the suction maybe a little bit further. So as you're going in, you're suctioning, and so then it keeps your video clear, and then that should be able to have a good enough view for you to see the cords and put in the tube. So that's one technique they can do if there's lots of bleeding in the oropharynx. And again, like we mentioned earlier, if there's any concern for base or skull fractures and maxillary fractures, avoid putting in an NG tube or doing any nasal intubation because you don't want to put stuff into the brain. And lastly, this is something I've read in Barash, but haven't seen in person, but something called a retrograde technique to intubate. So basically what you do is, if you're pretty much doing a needle cricotomy, so you have a 14 gauge through the cricothyroid membrane, you feed a wire or some sort of epidural catheter through it, and basically you feed it upwards towards the mouth and use that as a guide wire for the tube. So that's an option if you really can't see anything, and then you end up using a needle cric just to get a temporary airway. So that's something to keep in mind, keep in your back pocket. I personally have not seen it, but apparently that's an option to do. Okay, the next kind of injury is cervical airway injuries. And usually these are caused by either penetrating or blunt traumas. So signs and symptoms of penetrating injuries that affect the cervical airway are things like air escape, hemoptysis, and coughing. And signs and symptoms of blunt trauma to the cervical airway are things like hoarseness, muffled voice, dyspnea, stridor, dysphagia, odonophagia, cervical pain/tenderness, flattening of the thyroid cartilage protuberance, ecchymosis, and sometimes no symptoms at all, so they're asymptomatic. And the way you manage cervical airway injuries, according to Barash, the most ideal thing to do is using a fiber optic scope. And this allows you to visualize the airway as you're going through, and it prevents increased damage and edema as you're intubating. If it's possible, it's a good idea to get a CT scan at first, so you have like pretty much a roadmap on how to intubate. But according to Barash, fiber optic and cervical airway injuries is the best way to do it. For example, if a patient gets stabbed in the neck and the hole is big enough for the trachea, you can technically just put in a tube in there. Again, I have not seen this before, but things to keep in mind and put into your back pocket. And lastly, for these ones, if there's cartilaginous fractures or certain mucosal abnormalities, consider getting an awake intubation with the fiber optic. Okay, the last part of thoracic airway management is thoracic airway injuries. So again, the two major types, penetrating and blunt. Penetrating, the injuries to the thoracic airway could be pretty much anywhere that they got stabbed or got shot or something like that. Blunt trauma to the thoracic airway usually involves the posterior membranous portion of the trachea and the main stem bronchi, so within 3 centimeters of the carina. The usual signs of blunt trauma to the thoracic airway are things like pneumothorax, pneumomediastinum, pneumopericardium, subcutaneous emphysema, and continuous air leak. So if the patient is already intubated, signs of tracheal injury and things that suggest a tracheal perforation are things like difficulty obtaining the seal with the cuff, and large radiolucent area in the trachea when getting a chest x-ray. And assuming they're not intubated, the airway management strategy for blunt injury to thoracic airway injuries is to consider doing an awake intubation to maintain the peritracheal and peribronchial structures to make sure that they don't collapse on you if you are doing like an asleep intubation. Okay, so that was the crash course on airway management for specific traumas. And the last section we're going to talk about today is breathing abnormalities and pretty much how to manage it. So when you're in a trauma bay, the most deadly things that you have to look out for regarding breathing is tension pneumothorax, flail chest, and an open pneumothorax. Other things that could interfere with breathing and gas exchange, things like hemothorax, closed pneumothorax, pulmonary contusion, diaphragmatic rupture with herniation of abdominal contents, atelectasis from a mucus plug, and aspiration. So when you have a patient, especially, say for example, they get trauma to the chest, or they get in a car accident or something, get T-bone, bruising on the thoracic area. So keep these differentials in mind and be wary of these as you're evaluating the patient. And for the sake of time, we're going to just take a look at two of the major breathing abnormalities, tension pneumothorax and flail chest. So for tension pneumothorax, the classic symptoms for this, things like cyanosis, tachypnea, hypotension, neck vein distension, tracheal deviation, and diminished breath sounds. But for tension pneumothorax, you don't always have these symptoms. So just be wary of this. And then the definitive diagnosis tool is using a CT. Like you could use a chest x-ray, but a definitive gold standard way to diagnose is CT. But if you see that the patient is hypoxemic and hypotensive, coming in with a trauma to the chest, always think of possible tension pneumothorax. Okay, and in an emergency situation where you identified the pneumothorax, before doing the chest tube, it's important to do a needle decompression. And this is a temporizing measure, but it's going to be buys you enough time to toss in a chest tube. And the way you do it is you use a 14 gauge needle and you stab it into the 4th or 5th intercostal space at the mid-axillary line, or you can go for the 2nd intercostal space at the mid-clavicular line. Okay, the last thing we're going to talk about is flail chest. And this is actually kind of interesting because it's pretty board relevant. I remember getting a few Q-Bank questions on this one. So basically, a flail chest is when you have ribs that fractures at greater than 2 sites of 3 adjacent ribs. And this is with costochondral separation or possible sternal fracture. And then the underlying thing is possible pulmonary contusion, which could cause respiratory insufficiency or even failure. And this generally occurs over 3 to 6 hours and could be tracked with serial ABGs as well as chest x-rays. There's something called a rib score. It's pretty much a predictive scoring system for complications, and basically the higher the score, the higher likelihood of developing adverse things like pneumonia, acute respiratory failure, and a need for a tracheostomy. And the treatment for flail chest, the most important thing is effective pain control. Because if you think about it, the reason why people end up developing pneumonia or acute respiratory failure is because it hurts so much to breathe. Like I fortunately haven't had broken ribs before, but then I can only imagine how much pain it causes. So if you're able to control the patient's pain, they're going to breathe a little bit more regularly, and they're going to reduce the risk of developing things like pneumonia. So effective pain control, you can do continuous epidural anesthesia, you can do thoracic vertebral blocks, and these are things on top of the normal pain medications. In addition to these, you can give supplemental oxygen as needed, and then of course, for most of these trauma patients, incentive spirometry. Okay guys, thank you so much for sticking in for this episode. That is it for part 2 of the trauma anesthesia series. If you have the time, I would really appreciate it if you do the post survey. And in exchange for doing that, I'll give you a fun fact. And did you know the elephants can't jump? All right, thanks for tuning in. This is Scott, the anesthesia resident, and I look forward to seeing you in the next episode.